In Britain today, the number of people with dementia is 700,000. In the next 15 years, that figure could increase by 38%. Now, according to a recent report, there is growing concern about the widespread overuse of antipsychotics in care homes to treat people living with dementia.
Antipsychotics have been described by some people as a form of chemical restraint. There's some evidence that the medications can increase death rates in people with dementia. The problem is when they're routinely used just to calm people down, control behaviour, or as a substitute for inadequate levels of staffing or inadequate skills and knowledge and training among the staff, and they shouldn't be used routinely and unthinkingly.
At Sanctuary Care's Ashton Court Care Home for the Elderly, specialising in dementia care, the staff have taken up the challenge of creating a home where antipsychotics are rarely needed.
We're trying to allow people to have freedom. So we looked first of all at the environment and how we could make that enabling for people. And rather than have the traditional large lounge with chairs sitting all around and people looking thoroughly bored, we've created small areas and things to pick up and touch and feel, a nurturing environment. We actually use doll therapy. We have one lady who absolutely loves the dolls, and she's become more relaxed and just happy, really. At one stage, we had 5 new people coming into our home, all within 1 week. All these people had differing stages of dementia, and particularly during the evening, they were very, very restless, unhappy and worried. And the normal sort of thought would be, well, let's call the GP and they'll probably need something to calm them down during that evening period. But we looked past that. We looked at the person and tried to see what we could do without restraining them even further by giving them medication to sedate them. And so what I did was I introduced a new shift, and this shift was from 6 till 10. This one person was coming in just to provide comfort and a wind down time up until bedtime.
One resident who posed a dilemma for the staff was Des.
He used to put on golf tournaments. He used to take all the men that he played golf with abroad to Portugal, and he used to pay and treat them all and pay for all their flights, a lot. He was the most generous person you could ever think of.
Des had come to the home on a high dose of antipsychotics because of challenging behaviour.
He was very unsettled, very angry with life, and he used to pick up the furniture, pile it in the middle of the dining room, and talk about fire. He was just so angry and upset, and the first instance from the staff was, oh my goodness, we can't keep him here.
Family carers, professional carers have always said we can cope with what people can no longer do, so that's dependency, but we can't cope with what they've started to do. Now that's aggression, it's wandering, screaming, shouting, agitation, or just the downright bizarre. And because they can't cope, they want a solution. And unfortunately, those behaviours tend to be seen as symptoms. So if they're seen as symptoms of dementia, and dementia is untreatable, then logically the symptoms are untreatable. You have to control it. And how do you control it? You prescribe the antipsychotics.
Graham has a rule of thumb for determining whether a behaviour is a symptom of dementia or caused by other factors, such as frustration with the environment.
That which people with dementia share in common, you can attribute to the disease. That which they do not share in common, you can rarely attribute to the disease. You see, no one has any doubt that a person with dementia will have a poor memory, will not be able to communicate well, will make errors of judgment and be very dependent. That's what all people with dementia share in common, hence it's the product of the disease. But if you say that someone's aggressive because they have dementia, then logically they should all be aggressive, and they're not.
Graham Stokes' approach is to understand their difficult behaviours by examining a person's life story.
The recovery model is all about recovering the person. Now, what that means is, if the person who's caring would not wish that to happen to them, then why are they doing it to the person that they're caring for? So, for example, if a person with dementia is sitting in a lounge doing absolutely nothing, in that chair for hours on end, If the care worker would say, I could not tolerate that myself, then why should we expect a person who's living with dementia to be happy with that situation? You recover the person, you restore that person to life, and then you start thinking about, what is a person's needs? How do I actually know the uniqueness of this person?
In Des's case, the care workers made a remarkable discovery about his habit of piling furniture high.
We looked at his life history and we found that he was a painter and decorator. And in fact, what he was doing was getting everything, preparing to decorate. He would cover up televisions with sheets, strip off his bed. And so when we looked at that, just understanding what he was doing helped the staff. And we'd have a meeting and sit down and say, OK, how can we help this gentleman? We had paintbrushes and a roller and just some water in a tin. And he was just so pleased to be able to have some sort of meaningful occupation. And it's an important part now of his life.
It obviously is working because he's calmer, but when he's on a mission, You could say he thinks he's back in the Navy.
As a result, the staff were able to take Des off his antipsychotics.
It's such an important one to remember, especially when you're doing that initial risk assessment issue.
Sylvie Silver is director of NAPA, the National Association for Providers of Activities for Older People. She believes care homes can minimise the use of chemical restraints if they are prepared to re-examine their culture and attitudes.
One of the frequent issues that comes out in training with people saying, we're not allowed. If I had £1 for every time somebody had said it to me. And one of the solutions to that is to get the group of people together who have this belief it's not allowed and explore it. Which health and safety regulation, which company policy. And quite often, actually, they don't exist. They've become folklore that says we're not allowed. So, if we've got those issues, let's debate it. Let's get the manager together. Let's get the housekeeping staff along. Let's talk to the carers and say, how do we resolve this issue? That way, you're empowering people to think about what's going on and not be criticised for it. And if we can give carers the confidence, and I think that's what training does bring, is you go back from a training session saying, I did this yesterday and I heard this and I was told this is okay. It does challenge the systems.
We need to keep our people safe, but they have the right, just as anybody else, to be able to take risks. And as long as they're managed, you've documented things, and you monitor all the time, then people can have freedom to choose and freedom to live as they would wish.
Good morning. Hello.
You have to start from the top. The whole organisation needs to be behind you. The manager of the home needs to set the example. You can't just sit in the office. It won't just happen on its own. You need to lead your care staff. Staff have to know that it's all right to sit down and talk to somebody and share a cup of tea. And not only is it all right, it is expected. That's very much part of their care.
Des's risk has been reduced, his antipsychotics removed, and his dignity restored.
In here, it's a home, it's a freedom, and he can do anything he wants. And they don't shout, there's no restrictions, there's nothing. It's just a home from home. Absolutely brilliant.